pass to Frank, our research program manager, to introduce our guest speaker for the evening. Thank you, Frank.
Thanks, Ken. While I get started, would you give Kishore screen share rights? What we're going to do tonight, Dr. Kishore Kumar is our guest speaker. I'll introduce him in a minute. And tonight's topic is managing your spasticity, so a topic that is relevant to almost all people with HSP. But first, we want some of your story, some of your information. So would you go to the chat box that you've just done for Ken about wills and answer a couple of questions for me? The first question is, what do you do to manage your spasticity? Now, we don't need an essay. You can just put dot points, Botox, Aclofen, pump, exercise, swimming, whatever it is, stretching. So would you just go to the chat area and list the things that you do to manage your spasticity? Just take a few moments to do that. Someone's got their microphone open. Would everyone else just kill your microphones? Jim, it seems like you might have your microphone open.
Oh, okay. See if I can get rid of it.
If you drop your cursor down at the bottom of the screen, find your name, and you should be able to just click on the microphone icon.
Ah, is that it?
Bottom left. That's very good. Thanks, Jim. Just give you a moment more on managing your spasticity. Someone whose screen name is Supervisor24, also your microphone's open. If you would kill that, thanks. Good, thanks for that. Now, second question, also to be entered in the chat area, is what questions do you have about managing your spasticity? What are you unsure about, unclear about? What would you like to know? You can start doing that now. If you don't have any questions, but you get them as you hear Dr. Kumar start to present, please put them in at any time. And we'll go through and I'll pull the themes out of there, and so we can have the most targeted information from Dr. Kumar when he gets there. So take a moment. What questions do you have about managing your spasticity? And put them in the chat area. Sorry, the person with screen name Supervisor24, your microphone's open.
I haven't said a word. What do you want me to do?
Drop your cursor down to the bottom of the screen on the bottom left, and just click on the microphone icon that says audio, and that will close your microphone. Thank you. Steve, yours is open as well. Steve Acton, would you mute your microphone? Thanks.
Sure.
Okay, so feel free to add your questions as we go, and let me introduce Kishore. Dr. Kishore Kumar is a practicing neurologist with particular interest in neurodegenerative and movement disorders, as well as the genetics underlying them. He's currently based at Concord Hospital in Sydney, has a research connection with the well-regarded Garvan Institute, and connections with Royal North Shore Hospital, where he completed his PhD under Professor Carolyn Sue in 2014. As well as HSP, Kishore is an expert on spinocerebellar ataxia, which is a sort of a cousin of HSP in the same sort of family. Kishore's been a member of the Foundation's research team for many years and has always made himself available to lend his expertise and support to our work. Would you join me in welcoming Kishore here tonight as our guest speaker? And I'll hand over to him.
Thank you, Frank, for that kind introduction. And I have prepared a few slides, and I'd also like to thank Ken for inviting me also to talk. So you've already introduced me, but you can hear me okay and see me? Yep. So this, I work at Concord Hospital. This is at the neurology department and in the molecular medicine lab. So neurology department, we have a neuromuscular clinic. We see patients with HSP. And in the molecular medicine lab, we do genetic testing for HSP. And I also work at the Garvan Institute, where we apply advanced genomics for the diagnosis of HSP. And this is my disclosure side, and I've worked closely with the HSP Research Foundation previously. So you all know about hereditary spastic paraplegia. So this is a disorder that, if you think about how to define it, it's got weakness and spasticity primarily of the legs. So it's both of those things. But today I'll try to focus on the spasticity. But obviously it's hard to, separate those two things out. So then you might ask, well, what is spasticity? This is a disruption of muscle movements. It's really about muscles contracting all at once, even when you try to move or even at rest, and muscles remaining contracted and resisting being stretched. So it can interfere with movement, can affect your speech, can affect your walking. It can vary greatly in how it affects someone. Some people may only feel like a mild feeling of tightness in the muscles, whereas other people can, it can be severe, painful, uncontrollable stiffness and spasms. And so it can be linked with these following things. So when you examine a person for spasticity, you're looking, it's often at the knees, you're pulling the knee up, and you're looking for like a catch. So it's kind of velocity dependent. It's how quickly you move the muscle is related to the spasticity. It's a different stiffness than people, for example, with Parkinson's disease get. And then you may experience clonus, which is this, often it's at the ankle, where a fast involuntary muscle contractions, and your doctor, when he's checking for stiffness, may try to elicit clonus. People get brisk reflexes and muscle spasms, involuntary crossing of the legs, pain, discomfort, abnormal postures. And if you get spasticity for long enough, you can get shortening of the tendons and tendon contractures. And you can even get muscle joint and bone deformities. And all of this has a major impact on your life. It can affect your activities of daily living, ability to dress, to do showering, can disturb your sleep with painful spasms and muscle tightness. So basically, why does spasticity occur? Well, it occurs because muscle movements have a complex control system. So some muscles are told to contract and other muscles are told to relax. And if you damage the nerves in the central nervous system, in the brain and spinal cord, like in HSP, you can disrupt this complex pattern. And as a result, muscles contract all at once, which we can call co-contraction, and this makes it difficult to perform voluntary movements. I'm focusing on HSP today, but as many of you know, spasticity can be linked with a bunch of different conditions. For example, cerebral palsy, spinal cord injuries, multiple sclerosis, stroke, brain injuries, motor neuron disease, also disorders of the white matter of the brain that can all cause spasticity. And then the spasticity can cause different postures in the upper limbs. For example, often there's like a flexed posture of the arms, and the wrist can be flexed or the fingers can be flexed. Or you can even end up with a clenched fist, which can have a lot of problems if you need to have hygiene of the hands because you can't clean the hands properly. But for HSP, it's really the legs that are primarily affected. So you can get this kind of abducted thigh. So that your legs pull in, and when you walk, you can get a scissoring gait. You can also get, a flexed knee, extended knee. You can end up with plantar flexed foot. So that means that the toes push down, or this deformity of the ankle called equinovarus deformity. So these are all kind of the positions that you can get of the legs from spasticity. So I was looking at the answers to what people's treatment, the treatment people are already getting, and I'm dividing it up into like different categories. So you can have non-surgical treatments, and of course you can. Physiotherapy is a really good treatment. They focus on lower extremity stretching and strengthening exercise, mobility training. You may also see an occupational therapist. Again, they can focus on activities of daily living, how you do your grooming, bathing, and cooking, how you might go to work. You can have spasticity affecting the mouth, so you may need to see a speech therapist. Sometimes your allied health team may recommend casting or bracing or some assistive devices to help you manage spasticity. And then we can move on to pharmacological treatments. And these are some common medications you can use for spasticity, including baclofen. I saw many people are on baclofen. And then dantrolene. To us, baclofen is my go-to drug. You can also try diazepam, clonazepam, gabapentin. So as a bit of a summary, baclofen, it works by reducing the release of excitotoxin neurotransmitters. So it works on neurotransmitter release. This can help relieve the spasticity. And there are two ways it can be given. And I noticed from the chat that many people are getting it, targeting the delivery of the drug directly into this cerebral spinal fluid. This is called intrathecal. And then you can, most of my patients, they're getting it orally, so it's taking a tablet. So it's both of these different routes deliver the same drug, but they affect you differently, and I'll get to that in a moment. So baclofen, you can start at 5 milligrams 3 times per day, and you gradually build up the dose. The idea is by starting at a low dose and building it up, you can get a good response without getting knocked out by the side effects. So you can go up to about 80 milligrams per day in total. And the intrathecal baclofen will be a protocol depending on your spasticity levels. In the chat, someone touched on side effects of baclofen. And this is something that I always tell my patients what to expect. So it can cause sedation, and that's a big one to look out for, confusion, and it can make muscle weakness worse. And so it can cause dizziness and nausea. But the first three are ones that I always tell my patients about. So particularly the drowsiness can be a hard side effect to deal with. And if you administer directly into the spinal fluid, the intrathecal baclofen, you get a more consistent reduction in spasticity, and you don't get that side effect of the drowsiness because it's been delivered right into the spinal fluid. It's not affecting the brain. But there are a lot of complications that you can potentially get, including infections of the device, the pump might malfunction, catheters malfunction, spinal CSF leaks, so leaking of the spinal fluid, spinal infections and things. So it can be a very effective treatment, but because of these kind of side effects and it's an invasive treatment, I tend to not use it as much, but I think it has actually got reasonable evidence for it. So I had a look at the evidence, and I couldn't see any actual study for HSP for oral baclofen alone, but there was a systematic review. So systematic review is like going through the literature and pulling out all the studies and looking at it in a really critical way. And they studies report that your walking improves if you try the baclofen through this into the spinal fluid. And then, but not, so they have a subjective improvement, which means the patient feels better, but there's no objective improvement. Not all of the studies found an objective improvement, which means there's a measurable improvement in walking by an external person. Yeah. And so the most common side effect here was catheter-related problems. So this kind of supported the use of intrathecal baclofen as effective and viable option for the treatment of spasticity, especially if they're refractory to conservative therapies. Certainly you'd try oral baclofen first. So gabapentin. So I'm switching tack now to a different drug that you can use for spasticity, which is gabapentin. This is a drug that's used for epilepsy and nerve pain. And there was a test, it was tested in a double-blind study, prospective study, so comparing it with a dummy medication, which is placebo, versus gabapentin, and they didn't find any clinical difference between gabapentin and just taking the dummy medication, the sugar tablets. So there's not really good evidence to support gabapentin for HSP and spasticity. This is another drug that I found a study for called 4-aminopyridine or 4-AP. This is a drug that can be used for multiple sclerosis. And then they looked at this drug, 4-aminopyridine and HSP. There were only 12 patients treated for a short period of time, and they reported some improvement in the Spastic Paraplegia Rating Scale, which is a measure of severity of hereditary spastic paraplegia. But there was some problems with the study with no control group. And the second study, again, enrolled only 5 patients with HSP, and they showed an improvement in these rating scales. But again, there was no control group. So patients there was no people getting any dummy drug. So you can't exclude the placebo effect. And so I think this is a problem with some of the HSP and studying HSP in general, that the numbers of patients are small and the studies are small, and that usually have some problems with them, like there's no placebo control group for the studies. So this limits our ability to make evidence-based kind of judgments on what treatments to give people with HSP. And now in the chat, a few people mentioned that they're getting Botox injections. So this is another treatment you can get. Many people, when they think of Botox injections, they think of cosmetic surgery and getting Botox into the face. But in fact, Botox can be a treatment for spasticity. Here you're injecting botulinum toxin into muscles that are too active to partly paralyze those muscles and improve the spasticity. And basically, botulinum toxin works by blocking the release of this acetylcholine. So it stops the communication between nerves and muscles, or it blocks those signals to relieve the overactive muscles. And so this is a important trial where they looked at botulinum toxin type A, or type of Botox, in hereditary spastic paraplegia. This was called the SPATOX trial. So they took 55 patients, so now you're looking at a good number of patients. They gave botulinum toxin injections, and it was not able to, while it improved some things, it didn't really produce a functional improvement in the patient's function and walking. However, this trial did give a good outcome. Here they combined botulinum toxin with intensive physiotherapy. They looked at 18 patients, and they gave Botox into the hamstrings and the calf muscles, and they showed an improvement in muscle tone and in the speed of people walking and how far they're able to walk. And this measure, called the Spastic Paraplegia Rating Scale, improved. So there's a suggestion that if you combine botulinum toxin A and physiotherapy, this can lead to an improvement in spasticity and quality of life in patients with HSP. So this guides my practice a little bit. So for all of my patients, I'm trying them on physiotherapy, occupational therapy. If they're under 65, I try to get them on the NDIS, because I think that it's a progressive disorder and they'll eventually need the NDIS. So I'm trying to get them on the NDIS. I try them on oral baclofen. And if that doesn't work, I go for Botox injections, and I pair it with physiotherapy, and it can be helpful. But obviously, this is a really difficult condition to treat, and I think all the treatments would be, I would say, only giving a partial benefit and not giving a really powerful response. And so obviously there's a need to get better treatments for this condition. Yeah, so that was my short kind of summary on spasticity and management of spasticity in HSP.
Thanks, Kishore.
Yeah.
It speaks to the complexity and the difficulty that you describe, looking through the number of modalities that people are saying they use to manage their spasticity, covering medication, supplementation, especially magnesium. Gets mentioned, but multiple forms of exercise, stretching, weights, swimming, yoga, physiotherapy, both manual, electrical stimulation, even podiatry, and someone also mentioned meditation. And there's arguments to be said for a multi-pronged approach. All of this can work. Let's go to the questions, and I think the first one is from Tim. Do magnesium tablets help?
Magnesium tablets I would use for like a cramping feeling. So if you're getting cramping feeling, it's worth trying magnesium tablets. And I would say a fairly safe treatment to try. So anyone with cramping, I suggest magnesium. And can't use quinine anymore because it has some side effects. So that's why we don't use quinine for cramps.
Let me ask a question sort of lateral to that. Restless leg syndromes that a lot of people with HSP get at night, is that a form of spasticity?
Restless leg syndrome, in a way, it kind of involves kind of different. I wouldn't call it a form of spasticity. It's like almost like a different type of movement disorder. Also linked with dopamine and linked with Parkinson's disease as well. That's a condition that's difficult to treat. For example, you should get your iron levels checked. You may look for like a nerve damage in the legs. And it can respond to some drugs that you use for Parkinson's disease, like Cifrol, or drugs that bind dopamine receptors. But it has to be given with some care, because if you can end up, the medication can make the problem worse. So you just have to be careful about how you give that medication.
Good, thank you. Steve says, I struggle with balance. And again, pretty common across HSP. And what's the connection, Kishore, between spasticity and balance? And can you improve your balance without working to reduce your spasticity?
Yeah, so I think it's a lot like your neurologist has to examine you and see, is this a lot of spasticity with no weakness, or does this person have a lot of weakness? The drugs, if it's primarily weakness, Botox and baclofen probably not going to help very much. But if it's spasticity, that can affect your voluntary movements, your ability to bend your at the knee, and it can pull your leg in with walking, the scissoring gait. And then in that case, treatments for spasticity could be effective. Yeah. So the gait would, yeah.
Sorry, go on.
I mean, the unsteadiness of gait could be multifactorial. You know, people with, they get foot deformities, they get spasticity, they can have weakness, and you can have ataxia as well. Many patients with HSP have ataxia, which is a disturbance of coordination. So this can also affect your walking. Yeah.
And you just referenced there something which is, you know, the ongoing and almost unsolvable challenge with HSP is the continuum from strong spasticity to, you know, high levels of weakness.
Yes.
And that sort of sliding scale in between, where if you overmanage your spasticity, you can make weakness worse. Yes. Would you just like to comment on that in terms of spasticity management with HSP?
Yeah, because baclofen can make weakness worse. And Botox injection can also cause weakness.
And this is a fairly unique challenge to HSP that isn't with other diseases involving spasticity because of the weakness that's always there.
Yeah, I guess I think there's a lot of overlap with other conditions, like children with cerebral palsy may have very similar problems, and in fact, cerebral palsy can be hard to distinguish from HSP in children. Yeah. Yeah, so it can be, there's quite a bit of an overlap with the management of spasticity for HSP and other conditions. I would say that it's helpful if the neurologist who's giving the Botox has some experience with this condition, because it's not the standard, it's a rare condition and it's not a standard way to use Botox. I'm not even sure it's really covered properly by Medicare, this injections.
Okay. Laurie asks, she says, I take magnesium, but still experience Viagra legs about 10 times a day. Can there also be a vitamin deficiency or anything else? Do exercise, perhaps doing the wrong ones?
Yes, I think, are you saying with the legs, what do you mean by the Viagra?
Should I speak?
Sure.
Oh, yes,
go
please.
ahead,
Yeah, go ahead. Yeah.
Yeah, just that that they go like that they go out straight just involuntarily. That's what I mean by Viagra legs. I mean, that's not an actual term, but that's what I call it.
I think that's a very hard one to manage. But you could try targeted botulinum toxin injections. I'm sure you're trying some of the treatments that I went through just then. And yes, I think, yep, go ahead.
Definitely, but the first one, Botox, no. But I'm wondering also, how do you determine the correct amount of Botox to inject? How does that work?
Yes, that's why I think it's good to have someone who does these big muscles. People are often giving Botox to smaller muscles, like people with dystonia of the head, or giving Botox for migraine. But these are really big muscles, and someone who maybe has some expertise knowing the right dose. And there's probably there's a bit of a trial. So you give a dose, and maybe the injector may not give the full dose, give a smaller dose just to see how it goes, and then come back and give a higher dose next time. It's a bit of trial and error to pick the right dose.
So the importance of finding someone who's administering the Botox is used to doing it into the bigger muscles, and it has experience with HSP.
Yeah, I think that would be helpful. Yeah.
Hmm.
Yeah.
And
Personally, I don't give Botox. That hasn't been something I've focused on, but I do know people who are good at doing HSP. Yeah.
And if you do it, it's about every 3 months.
Yeah, every 3 months.
Right. And so if you don't get the dose right first time, they sort of sneak up on getting the right dose, judging by.
They could give a top up if it was not enough. If you give too much, you're stuck with it for 3 months, but it will go away after a few weeks. Yeah, but you are stuck with it for a while. Yeah.
Can I just ask one? What you said that that spasticity might also be connected to back pain or to something.
Yeah.
I think you said that. Can you talk about that?
Yes. Obviously the way that you're walking is not the biomechanics of the walking is really abnormal. It's going to put strain on your joints, like your hip joints, your knee joints, ankles, and also the lower back. Yeah. So working with like your physio to help with the gait and the posture to reduce the strain on your lower back and reduce this secondary kind of musculoskeletal injuries and things would be helpful. Yeah. If you did get like a pain in the back shooting down your legs, your doctor may think, oh, I do an MRI of the back or something just to look for some additional nerve root impingement. Yeah.
Nancy says she developed a herniated disc, which led to back pain, limited her ability to exercise. Spasticity has increased as a result, and wants to know how to get back to the prior level of functionality she had.
Yeah. So if you have a herniated disc pushing on a nerve, you may want to, that could be investigated with like an MRI of the back, and then there are different treatments. Sometimes for pain, you can give a little injection of local anesthetic or steroids that can cause a temporary improvement in symptoms. Or you, if it's in certain cases, if it's causing weakness in the leg, the herniated disc may need an operation. So your GP or neurologist may refer you to a surgeon to address that. Yeah.
Are you surprised that it's associated with an increase in spasticity?
The herniated disc, it doesn't cause spasticity on its own. Spasticity is caused by a central nervous system problem. So that's the brain and the spinal cord. Once it leaves the spinal cord, it's no longer causing spasticity. Yeah.
Okay. Norma asks, how does white matter in the brain affect spasticity?
White matter in the brain is called like a leukodystrophy, and that is again can cause a central nervous system lesion, and then that can cause the pathway is called the corticospinal tract, and if that pathway is damaged, this can lead to overactive muscles, and that's how it can cause spasticity. And in fact, there is an overlap between these white matter disorders, leukodystrophies, and HSP. There are certain genes, but I could mention, but that are like PLP1 and TUB4A that can cause both HSP and leukodystrophy. Quite a few genes can do that. And people, white matter lesions can be seen in different forms of HSP, like SPG11, for example. Yeah.
So not everyone with HSP will show up an MRI with white matter lesions, but some do.
Yes, some do. Yeah. If you have pure HSP, there won't be any white matter lesions. And most people with SPAST, the gene SPAST, don't have white matter lesions. Yeah, SPG4. Yeah.
Jill writes that the side effect that she experienced most troublingly was depression. Never had experienced depression any time in her life. Is that in Jill? Just confirm, is that in response to baclofen or Botox or something else? You can open your mic if you like.
Frank, it was baclofen.
Thank you.
It was baclofen, and I was really quite surprised about it. And I'd never thought that depression could be a side effect of baclofen. And it was only, I'm sorry about this, but it was Google that told me that it, I'm sorry, I know, that it is considered to be a side effect. And I can say it was horrendous. I've never had depression in my life before. So anyway, and I stopped the baclofen and the depression went. So it seems as though the two were most definitely connected. And I've never taken baclofen since. And I'm not really sure it helped me all that much anyway. Don't know.
Yeah, I would say the treatments are just not very satisfactory, to be honest. We're trying anything, and I wish there were better treatments. Yeah.
Yeah.
And then the baclofen causing depression. I haven't had that experience much with my patients, but I'm pretty sure that that's a side effect. Yeah,
I think
we
it
try
was
to cover
Mayo
the main
Clinic
side
as well.
effects. Yeah.
I think I got the information from the Mayo Clinic or somewhere.
Yeah, that's right. Yeah.
Half decent.
Yeah.
Anyway.
And I'm guessing from the thumbs up that someone else has also had that issue that Jill describes there with that symbol. I might be wrong on that.
Hi, Frank. That was me. Yeah.
Oh, you, Tim. Yeah. So for you as well.
Yeah, I experienced depression side effects, but that was with the oral treatment.
Oral baclofen, right?
Yeah, same.
And the response that I told my neurologist about it, and he recommended the pump.
Yeah, the pump won't cause that. Yeah.
Oh, okay.
Yeah.
The pump won't cause that. Obviously, it's not going into the brain. It's just going to the spinal fluid. Yeah.
Right. Okay.
Yeah.
Yeah. Anyway, I don't, and Botox, I've been assessed for Botox, but both occasions the physio said no, it wouldn't help me. So I don't do anything really except exercise.
Yeah.
Yeah.
Thanks, Jill. Thanks, Tim.
Thanks.
Norma says that are there studies published for intrathecal baclofen? Yeah, there are lots of studies. Kishore referenced one in the systematic review. If you go to a website, Norma, and just enter intrathecal baclofen as the search term, you'll see a lot of research studies will come up. And as just to reinforce what Kishore said earlier, there is a good evidence base for intrathecal baclofen being effective in HSP. Doesn't mean for everyone, but over a decent number of studies and people, it's been shown there's evidence for its effectiveness. Laurie asks, is there another name for the MS drug?
Famipridine? Famipridine?
Dalfampridine, Fampira.
Yeah, Vampira. Yeah. It's a little bit expensive because I'm using it for a different condition with episodic ataxia. And you can get it from a compound chemist for a little bit cheaper. And I think there's only minor evidence for it because I think those studies had very few patients. They were not good studies, I would say. Not because of the investigators. It was just because it's such a hard condition to study. Yeah.
Shez Hay says, most of my falls occur when turning.
Yeah. Turning is a common circumstance where people fall, obviously, because that's when you can become unbalanced. So you could talk to your physio or OT about strategies to avoid falls with turning. And some people, take many steps with turning or just take it slowly. Obviously, there's different ways to avoid falls, like a stick and that type of thing. And I'll just throw in there that people, you may be at risk of osteoporosis, and it's worth getting a bone density test to make sure if you do fall, your bones are strong.
Kishore, just scroll down a little bit in the messages.
Okay.
There's a question from Christine about she's done some homework on some vitamins and supplements. Would you like to go down that list and make any comments? And the question is, can you make any comments on the benefits of those for people with HSP?
Coenzyme Q10 often gets a lot of attention for mitochondrial disease. And some forms of HSP are mitochondrial diseases, like SPG7, but there's very little evidence that this works. Creatine's like muscle building, and I would say that none of that doesn't work. Vitamin E doesn't really work unless you had there are some problems with ataxia with vitamin E deficiency. So it's not really HSP. Ataxia it's worth if you had ataxia that your doctor does a vitamin E test. And then NAD, again, that's often relating to mitochondrial function. And I would say that there's no definite evidence for that. But if you found the study, it's always worth, I could have a look at it and say, oh, this study, where's the study at? Has it undergone a proper trial to prove this treatment works? Vitamin D, I would recommend you get vitamin D tests, and if your vitamin D is low, to replace it, because that's important for your bone health. And then branched chain amino acid supplements and arginine. I don't think that works. Although there's some amino acids, some very rare form of HSP is related to amino acids, but SPG9A. But I don't think that there's any proof for the branched chain amino acid. And arginine can be a treatment for some mitochondrial disease when patients have a stroke, but I don't think that there's any evidence for HSP. Yeah, so from that list, I would say vitamin D. If you have to check your vitamin D levels, if it's low, to treat those. If it's relevant, you could check your vitamin E levels, and that could be treated if it's low, and that could indicate a different disorder.
But no impact on HSP.
I don't think it has any impact on HSP. The one that really, I think vitamin D is the most logical one there that I think is got the best evidence for it. But there may be some trial that I haven't seen that there could be something that I didn't notice, but I don't think anyone's giving those medications for HSP.
And did you comment on alpha lipoic acid?
Yeah, again, I haven't seen that used, and I haven't seen the literature on that. Yeah, normally if someone's sent me that, came and asked me, one of my patients, then I would just do a literature search with them to see what the evidence is, just to see whether it's worth giving it a go.
Yeah, I sorry to interrupt. I have got a little bit more information on each of those
Yes.
Vitamins. So if you wanted me to send through,
Okay. Yeah.
It's a bit of I didn't want to send the whole thing, but I've definitely got more information. I mean, a lot of the vitamins were to do with like helping muscles strengthen, and I guess I was just looking at other ways to sort of keep my fitness and strength up.
Yeah.
Email them through to inquiries, Christine. I'll pass them on to Kishore.
Yeah. I'll have a look and see, and you can tell me what study you found, and I'll have a quick look. Yeah.
Yep, no worries. Okay.
Yeah, 'cause
Yeah,
it's got to
I
be
mean, it
something I didn't
probably is
notice.
not really studies, it's just really content
Yes. Okay. Yeah.
about so anyway.
Kishore, to be fair to say that in various forms of the 90 or so HSPs, there are deficiencies in some of these factors. However, the problem isn't solved by supplementing with like CoQ10, for example.
Yeah.
No.
Yeah, that's correct. Weirdly,
Can I
yeah.
make one more mention? Just I always look at sort of other like ways to sort of have like vitamins or natural other ways to try and tackle some of the issues. That's why I was just asking. But
Yeah.
thank you.
Yep, no problems. There are some neurogenetic conditions that do respond to like serine and all sorts of things. So the field is changing very quickly, I would say. Yeah.
Ken mentions changing direction due to something unexpected is the big challenge.
Yes. Yeah.
Yeah.
That's is that the challenge? Changing direction and then falling down. Someone yells your name and you turn around and then fall over. Is that what you mean?
Yes,
Yes.
Keith. I mean, I'd be out walking my dog, and then something comes from the other direction, and the dog's
Yes.
going one way, and I change direction, and
Yes.
I lose my balance. So
Yeah, this can be a hard one to address. Yeah.
And of course, this is the problem with HSP, isn't it, Kishore? That balance itself is actually okay in people with HSP. It's the lack of responding in time to disturbances to balance.
Yes, it can be. I think that's a good description of how that if you had some disturbance, you're less likely to make those adjustments to stay upright. Yeah.
And Tim mentions also going uphill, downhill.
Yeah.
Increases the challenge.
People might have trouble on stairs, for example, up and down stairs.
Jackie mentions NAD has weirdly helped me.
Yeah.
Also, protandem, I think that should be, and magnesium also.
Yeah.
In what ways?
Some people find those things. If someone found something helpful and they're finding it useful, I think that would be reasonable. Yeah.
Jackie, how have those helped you? Reducing spasticity, better sleep, less cramping?
The NAD has, I can't explain it, but I'm stronger in a lot of ways. Like I can put my feet on my wheelchair before they would spasm and go up. I had trouble holding them now. And the Bertandem has eliminated my hand spasms and my Raynaud's syndrome in my hands. And I think the magnesium really helps my spasticity at night.
Okay.
Thanks. All right. That seems to be it, Kishore, and we're only a little bit over time. But thank you for that, and let me pass back to Ken.
Thank you, Frank. And wow, a big thank you, Kishore, for your time and your expertise tonight. I'm excited for a number of reasons. Well, I mentioned the focus of the foundation, education, treatments for HSPs. You covered that pretty well, so thank you on that.
Yep.
And the other exciting thing was the global factor involved in the people that have been involved in the meeting tonight. Having a global focus, I think, is very important. One of the things you mentioned was the challenges in the numbers for studies. When you think in Australia, we probably only got 2,000 people with HSP. Globally, what, 600,000 people trying to do some sort of trials and tests. It's a challenge where you're going to have a placebo or you're going to have someone on a drug. So you mentioned that tonight. I mean, that's just, well, it's confirmed the challenges that we have with a rare disease such as HSP. But look, I'm sure everyone here tonight would have greatly appreciated your time, your comments, your feedback. Look, fantastic. thank you very, very much for that. And thank you for everyone who contributed to making that a very, very good session. Thank you.